This is part 2 of the diverticulitis episode that we did. Again, we're trying to break this into digestible format. We all know that EM docs have ADD, and it's hard for us to sit down and listen to a podcast for more than 15 to 20 minutes long. That's what the research shows. It's just joking. That's basically what we think the research would show. Anyways, this is part 2 of diverticulitis management in the ER. The first episode focused on how there's been a significant change in the way that we manage diverticulitis, especially over the last few years. It's a condition that we often see in the ER, so it's really important for us to know how to manage it and how to treat it with the most up-to-date, with the most evidence-based, guideline-based therapy. So if you missed that episode, make sure you listen back to it. We know that it might stir some controversy, but there really shouldn't be controversy with limiting antibiotic usage and the cases where to limit it. That's what we talked about in the first episode. This episode gets more into the nitty-gritty of treatment, more into the nitty-gritty of what you tell your patients and how you can help prevent this and some of that outpatient management that you're going to be doing. Enjoy. By the way, we just launched a new merch shop. So if you want to get some Board Bombs branded material or just general emergency medicine, just cool content, sweatshirts, stickers, things like that. The holiday season is upon us. Check it out.
Yeah, so close follow-up's important with these patients. You know, I'll be realistic here. There's so many patients that at least I take care of, and I'm sure you both do as well, that don't have follow-up, and it's really hard to get follow-up within like a 3-day period. It's not the end of the world. If that's the case, at least within a week is good. It really just giving those generous return precautions. So they have a high fever. I usually give the patient the oral thermometer we use in the ED, and that's their little souvenir.
Oh, nice. You guys have those. Wow.
And they can take it home with them and they can use it.
Yeah.
Oh, yeah, we definitely do. Yeah. I don't believe the temporals. They're total lies. So anyway.
Yeah.
Okay, let's go.
Can we talk about that for a second? Why
oh my God.
Okay, let's go. Let's get ready for the rant.
I understand why,
okay,
of course.
Tell me about your
method, but
I hate them. I hate them so much.
So what do you hate, Blake?
Temporal thermometers. They're absolutely absurd.
Right.
First of all, the studies show they don't correlate to oral thermometers at all. Second of all, whoever cleans those things off, have you ever seen anyone actually wipe the little knobs on the top? Absolutely disgusting.
And
I don't even
it
get
actually
close
physically
to that
like
sweaty,
it goes across,
forehead.
right? Like, I saw that being done the other day. Yeah,
it's like a nice swipe.
It's not even like
it's
a zap or
it's
something.
Absolutely disgusting.
It just
Yeah. We use it for all the wrong reasons in healthcare. When they come in to do vitals and they scan their forehead and do it, I just roll my eyes. I have to walk out of the room sometimes to decompress because I just can't see it. And I'll walk back in later, either myself or I'll send the med student in. Hey, can you go measure this patient's temperature with a thermometer, an oral thermometer?
I mean, and you
get an accurate measurement.
You know when it's been used because you get a sepsis alert for the patient having a temp of 35.1.
Yeah, it's always hypothermic. Right. Yeah, exactly. In fact, when it's 99 on the temporal, I'm like, well, this could probably be like 104.
They're
or
clearly
98,
very ill.
Who knows? It's absolutely unreliable.
It swings the needle
absolutely
so much in the
worthless.
ER, right? Because you can have a stroke patient and everyone's doing all the stroke stuff and TPA is about to be pushed and someone's like, this patient kind of feels warm. And you're like, oh, their temperature is 104. It's like, wait.
Absolutely absurd. I cannot believe we've gone this. I mean, and of course, someone up in the C-suite somewhere said, hey, look how much money we're saving on these temporal thermometers. We don't throw them away. We don't, you have to buy oral thermometers because I'm sure they cost money.
Yeah, I'm sure on their Excel sheet, they noticed that line item.
Someone got promoted for that. Someone got promoted.
Temporal thermometers.
And then it spread.
to blow up in the ER. This was not a thing. This was not a thing before.
Have you seen,
no, it wasn't.
The cartoon where it shows
Maybe
the
it's
person
COVID?
It was during COVID when we're like, well, we can't stick anything in holes anymore. We'll just rub it across your forehead.
But they still didn't clean the knobs off. So anyway, let's move on. So, close outpatient follow-up is important for these patients. We all want our patients to follow up within 72 hours. That's unrealistic. We all know that is difficult for patients to do. That is not a contraindication to discharge without antibiotics. However, emphasizing coming back if they have a fever, give them an oral thermometer as a souvenir. Hopefully your department has oral thermometers.
You guys are bougie in Tennessee. All right.
Speaking of
North Carolina. There you
Dolly
go.
Parton's Tennessee.
How complicated diverticulitis?
Sure.
Let's talk about this. So it's really 4
Yep.
points here that don't include antibiotics.
Let's go.
Iltfat, you ready to hold up fingers? Number 1, clear liquid diet. People are not going to be excited about this. But clear liquid diet is important for at least 24 hours, and then they can advance as tolerated, just like your pancreatitis patients. Pain control is important here. So Tylenol is great. A lot of people don't like saying they're going to go home just with Tylenol, which we're not sponsored by the way, acetaminophen. You want to avoid NSAIDs here. Some studies have suggested that NSAIDs can propagate inflammation more, possibly associated with complications. So if the patient's pain is not controlled with high-dose Tylenol, then you can talk about doing low-dose opioid therapy. You can talk about oxycodone or hydrocodone for them. Antibiotics are optional here, though, and they should not be given routinely. If the patient has complicating features or the risk factors we mentioned, you're really going to prefer amoxiclav here.
Please.
You really shouldn't be doing ciprofloxacin or metronidazole. Please stop doing that.
Yeah.
There should be no time in your entire career from now on that you're giving ciprofloxacin.
Yeah, stop.
I can't think of one.
What if their mom told them that they had a rash when they were a baby to penicillin?
Well, then you're going to do one of my favorite new activities, my new favorite pastime, which is, of course, with patient permission, you are going to challenge your allergy. And I have never had a patient decline that. Because every time I go in the room, I tell them what the deal is, tell them what, hey, this limits your antibiotic exposure, limits the amount of good antibiotics you're able to get. You're going to be safely monitored here. This is a great place to do it. And we'll make sure that, you're taken care of. You can eat something while you're waiting after you get your first dose. Watch them for about 45 minutes to an hour, and boom. The last thing is going to be that close follow-up we talked about. If possible, if they don't have a PCP, refer them to your healthcare network. Instant customer.
There you go. Outpatient management of uncomplicated diverticulitis.
Yes.
It's pretty straightforward. And hey, so the last part I do want to mention here, because a lot of people I know there's some of you that have listened to this part and they're like, I'm still giving antibiotics. I'm gonna get this patient's gonna come back with a perforation and I'm gonna get in trouble and all this other stuff, right? Can somebody set me up on this? You guys know where I'm going. Somebody set me up with the question.
I feel like the question then of the people you just mentioned, they're definitely framing it and asking it in terms of, do antibiotics prevent progression to perforation or microperforation in low-risk patients? So basically, if you don't give antibiotics for uncomplicated diverticulitis, they're going to come back in less than 72 hours or so with a perf of some type.
The answer to that, do you know what the answer to that is, guys? No.
Gee, I wonder.
Antibiotics do not prevent progression to perforation or microperforation in low-risk patients with uncomplicated diverticulitis, right? So again, in patients with uncomplicated diverticulitis, just low-risk features that have none of the high-risk features we talked about, your antibiotics are not going to help. The American Gastroenterological Association, they found in their systematic reviews and meta-analyses of just multiple studies that they did. And one of these included like 2,500 patients. There was no difference in progression to complications among patients treated with antibiotics compared to those treated without antibiotics, right? So again, there was really no difference, right? And again, we're talking about uncomplicated with low-risk features present. So please, let's stop perpetuating this myth that somehow giving antibiotics is like stopping a perforation from happening, which just doesn't even make sense. Like, literally think about that. Does that even make sense? Like, what is diverticulitis? I mean, it's like just inflammation. Like, what are we doing here? What are we doing?
You know what is a complication?
Oh, I know where you're
preventable?
going here. Say it.
C. diff.
Yeah, that's one complication. Yeah,
really just diarrhea in general. Worsening diarrhea. It's like telling the patient with diverticulitis, like, hey, you have diarrhea. Do you want more diarrhea?
I don't understand.
I literally say that to them. Yeah. I do literally say that to them, and I've never had them say, well, I would like more diarrhea.
When I do send these patients home, I will tell them that their primary care doctor, might see the diagnosis I gave them, and the fact that I'm not giving them antibiotics, and think I'm crazy. And I'm pretty honest with the patient. So I would say that if you're sending patients home without antibiotics, you you should have that discussion with the patient. My kind of discharge stuff is I give, as Briggs, you mentioned, I give good precautions. Like, hey, if you have like persistent fever, you're feeling worse, not able to tolerate PO, just come back, to the ER. We'll take care of you, and, you'll need a reevaluation at the time. But I also am very frank with them. And I say, yeah, when you tell your primary care doctor I didn't give antibiotics, there's a good chance they're going to look at you skeptically, and they're going to do the whole, on the ER, what were they thinking? And not realize that, for the most part, guidelines have been updated for so many years, right? So just an FYI there. That's another thing that I add on when I'm discharging home these patients. And if I am giving antibiotics, I have not given ciproflagyl in at least 5 to 6 years since these guidelines have come out. Yeah, my gosh. Just please, amoxiclav, right? Just give that, it's better even just to give isolated fluoroquinolone, right?
Yeah. So if you're admitting them inpatient, NPO, IV fluids, these are the patients with complicated or severe cases. You want IV antibiotics that cover your gram negatives and your anaerobes. One hit Zosyn. I like that.
Piperacillin.
Oh my gosh.
Not sponsored by Zosyn.
Yeah.
Oh, not sponsored by Zosyn, of course. Piperacillin tazobactam is what you heard me say. Surgical consult, if they have an abscess greater than 3 centimeters, you can get IR drainage. If they're peritonitic.
To admit to medicine.
Yeah, they will.
Let's be real.
IR is gonna. IR doesn't admit the patients.
Yeah.
What?
The funniest is when people are like, "Oh, surgery manages even complicated diverticulitis," and you're like, "What are you talking about?"
It's
right?
like them managing pancreatitis.
This is all IR's game now.
If it's their first episode, let the patients know there's a fairly high rate of recurrence, 20 to 30% within 5 years. Things they can do to limit recurrence. The carnivore diet is not one of them, unfortunately, for our patient in this question stem. The risk will drop with a high fiber diet, exercise, weight control. Bleeding, a patient having bleeding, remember that is probably diverticulosis. Painless rectal bleeding, not diverticulitis.
Tell them to eat
the
seeds
whole
too.
seed thing is okay.
Yeah, they can eat seeds.
Yeah.
That is, it's so bogus. And it's so funny that I still hear people being educated on this. Patients will tell me, these poor patients, they deserve better. These patients are like, they told me never to eat seeds again. And then they're eating McDonald's or something. And I'm like, no, you need to be eating seeds.
All right. So some common board traps when it comes to diverticulitis. 1, treating every episode with antibiotics is no longer standard. You will be tested on this on the boards. Acute, uncomplicated, mild diverticulitis with low risk features does not need antibiotics. 2, ordering urgent colonoscopy. Do not do that acutely. There is a risk of perforation. Also, why are you ordering a colonoscopy from the ER? 3.
It's always an option on the boards, though.
It is. 3, assuming right-sided pain is appendicitis. That's not always the case. Remember, younger patients and on the boards, Asian patients have a risk of right-sided diverticulitis. 4, missing perforation because pain improves after antibiotics. You should be checking for free air on a CT.
Done.
So even if you don't like this whole thing that we're saying, you will be tested on the boards and the ITE for this.
And lastly, this isn't anything new.
That's it.
Okay? Because
exactly.
Yeah, you tell people this, for some people. And they look at you like you've got a third eye, and you're practicing wacky medicine, and they're like, "Is that something they do in Europe?" And it's like, wait, hold on.
That's crazy.
Our Europe colleagues, by the way, hey, shout out to our Europe and non-U.S. listeners. We've got tens of thousands of people out there that do that. Thank you. But they're probably just laughing at this whole episode.
Oh yeah. There's many reasons why. Let's be real.
They're also laughing because they're like, "Wait, you guys get CTs?" they're like, "We just diagnose this and then get white count and CRP to risk stratify, and we're done."
Yes.
What are you guys doing?
Exactly.
So
right.
They're laughing at that too. But also, again, AGA. These guidelines have been out for years. Other specialty societies. Yeah, and it's not just them either, right? It's other specialty societies that have done this as well. So let's even get into that. So like the American College of Physicians in March 2022, they updated their clinical guidelines on this. The American Academy of Family Physicians, they endorsed the ACP's recommendations in February 2023. So again, there's like multiple specialty societies, and this is based off of just rigorous reviews. Like you look at like Cochrane reviews that are done on this as well. So it's, basically what I'm saying is, yeah, we've got the
brought the
receipts,
receipts,
as the
That's
kids
what
would
said.
say, check the receipts. And
Oh,
it's
God.
pretty obvious what you should be doing here. And it is harder to have that conversation and to sit down, right? Because I'm been practicing medicine the longest here of this group, right? And I remember being a resident, and man, it was diverticulitis, super easy, right? You're done. Diverticulitis, ciproflagyl, nuke their abdomen and discharge them, right? Like you were done, and there was no like further conversation. It was like a 2-second long conversation. Now, yes, pause, as Marlena mentioned. Marlena, who has a MD PhD, mentioned so easily. Use your brain and think, right? Like just stop, pause for a second, think like, do I really need to be giving this patient antibiotics or not? And then understanding that in those patients with uncomplicated diverticulitis with low risk features, again, that have no high risk features, even giving antibiotics to quote unquote cover myself isn't going to change if they, change them from having a micro perforation as well. So that's it. Mic drop.
Mm-hmm.
We're done.
Mic drop.
Great to see you
Soapbox.
guys.
Done.
Yeah.
We'll catch you next time. Thanks for listening to Ian Board Bombs. Check us out, ianboardbombs.com.